Right, it's 4:30 and we've got a quorum already, so may I now call the meeting to order. Item 1 on the agenda, confirmation of the minutes of the special meeting held on the 26th of October. We haven't received any proposals for amendments. So can we confirm the minutes, please? The minutes of the special meeting? All right, thank you very much. Agenda item number 2, information papers issued since the last meeting. We haven't got any such papers. Agenda item number 3, items for discussion at the next meeting. We have the list of outstanding items for discussion and the list of follow-up actions. So can we invite the administration in now? The next meeting will be held on 21st of January, Monday, 4:30. The administration has proposed the following items. Policy address briefing from the Secretary for Food and Health, and then secondly, provision of obstetric services in the Cheung Kwan O Hospital. All right, PA briefing and obstetric services in the Cheung Kwan O Hospital. So 2 items for the time being, because we do not know how much coverage there will be in the policy address in relation to health services matters. So if you have other items to propose, you can always contact the Secretariat. So I would like to welcome Professor Chan and her team. So next time we will have the PA briefing from the administration, and also we'll discuss obstetric services in the Cheung Kwan O Hospital. We haven't received further proposals from members on items to be discussed next time. All right. Item 4 on the agenda, revision of fees and charges for private patients and non-eligible persons in the hospital authority. I believe members have already received the administration's paper and the background brief from the Secretariat. So, Under Secretary, please. Yes, thank you, Chairman. Thank you, members. I have to apologize to members because I have almost lost my voice because I'm not feeling too well. Sorry for that. But then I have my team with me, and so I may ask my colleagues to supplement when the need arises. So this paper reports on the review of fees and charges for non-eligible persons and private patients in the hospital authority. The hospital authority has carried out a review, and it is proposing to adjust the fees and charges for these 2 categories of patients. Now we attach great importance to the needs of eligible persons, and so I want to say that in fact we provide a service to them which is heavily subsidized. But then when we have surplus capacity, we also provide medical services for non-eligible persons. But the principle is that the cost has to be recovered. The hospital authority, apart from providing services to NEPs, also provide services to private patients, mainly at Queen Mary Hospital and the Prince of Wales Hospital in Sha Tin. So the public can have access to specialized expertise and facilities at these hospitals which are not readily available in the private sector market. And such as patients will be charged according to the cost or the higher of the cost or the market price of the service. The last round of major revisions in fees and charges for these two categories of patients was in 2003. In other words, about a decade ago. And during this period, market prices went up. And so our present fees and charges are much lower than the costs of such services. So the hospital authority conducted a review to make sure that public money was well spent. And so we are proposing to adjust these fees and charges upwards by 44.5% and 45% respectively for these two groups of patients. And we're talking about an annual average increase of 3% when you divide these percentages over a 10-year period. These new charges will come into effect on the 1st of April next year. And the review doesn't cover eligible persons. In other words, Hong Kong permanent residents can still continue to enjoy public sector healthcare services which are heavily or highly subsidized. And then there is also a technical revision, and that is in relation to the definition of eligible persons. As members may recall, in January last year, some members of the panel pointed out that all Hong Kong ID card holders were regarded as eligible persons. But then, when the Immigration Amendment Ordinance was enacted, the situation changed. There were some who left Hong Kong permanently, but they did not surrender their ID cards when they left Hong Kong, but then they were no longer regarded as permanent residents. In other words, they would not be regarded as EPs. But then previously, when they produced their ID cards, they were still regarded as EPs and were treated as EPs. And that will, of course, have some implications to government revenue, and that's why we have this round of revision. In fact, we obtained funding from the Finance Committee on the 28th of January 2011 to implement the project of online checking of the eligibility of non-permanent Hong Kong ID card holders for subsidized public health care services. This online checking system seeks to verify the status of those who hold ID cards but then who are not really resident in Hong Kong. And that's why we need to revise the definition of EPs so that in future EPs would only mean Hong Kong residents. But of course this is only a technical amendment, and Hong Kong residents will still be EPs and will be able to enjoy our heavily subsidized public sector healthcare services. Thank you. Okay. Mr. K.K. Kwok and Mrs. Regina Ip. All right, 3 members. I think we have sufficient time to allow each member 4 minutes. Mr. K.K. Kwok. Yes, Chairman, I can understand why the administration is proposing upward revisions in fees and charges. I think there should be a distinction drawn between non-eligible persons and private patients. Now, some NEPs are in fact mainland spouses of Hong Kong residents. Now, you can see this has given rise to a lot of tragedies. These mainland spouses of Hong Kong residents hold, or many of them hold, two-way permits or multiple trip permits, and when they're in Hong Kong, sometimes they have to be hospitalized, but then when they are admitted, they are discriminated against. Let me explain. Now, for Hong Kong residents, if the spouse is of other nationalities, for example, Nepalese, Pakistani, Indian, expatriates, Australian, the US, then these spouses can easily get an ID card at the immigration department, and they are given PR status. And so they can enjoy the eligible person rate, in other words, $100 per day. And I think in fact, there are a lot of Hong Kong mainland marriages, and I think this policy of the HA has given rise to a lot of tragedies.
So there are cases where women do not see a doctor even as she has cancer. Look at the figures. It's just impossible for these women to afford the costs. For general bed, 4,600. General ward, 4,682. Or, 23,000 for ICU. Even blood tests or other radiographic services cost more than $50,000. So it costs them tens of thousands of dollars to give birth. So given the costs, I think the government and the HA should not continue to use a discriminatory policy. You can imagine that, non-Hong Kong couples or, spouses who are not Hong Kong residents should not be discriminated against or treated, unfairly, particularly for the women from China. Whether the government or HA should, at this time, now that you're reviewing the fee and charges, you should look carefully at the category of NEP. I know some of the members of the NEP maybe are just people on transit or tourists, who has taken out travel insurance anyway. So you need to charge them full fees. But for mainlander spouses of Hong Kong people, they are in a different category and they're in actually vulnerable position. Yes, mainland spouses. Thank you, KK Kwok. Our mechanism is such that we would look at the identity of the end users of our services. So, as I said, if their spouse is a Hong Kong person, then under the current mechanism, of course, no consideration is given whether their spouse is a Hong Kong resident. But I know the examples that you just mentioned, we are aware of that. And the review of the existing fees has not taken that into consideration, because maybe Dr. Yuan can supplement later, but HA's consideration is on the cost and inflation and revenue as the basis for the exercise. We would not actually take into consideration particularly the various types of NEPs, or whether the spouses are from Hong Kong or not. But maybe Deacons could supplement. Dr. Yang? Yes. Chairman, members. Just then, Mr. Kwok mentioned about the particular category of NEP. For us, everyone who uses our service is provided services on the principle that services are mainly for local residents. If there are surplus places, we would exercise discretion. If it's in case of emergency, we will also exercise discretion. But for NDPs, we need to charge them according to the existing level for NDPs. We do have a mechanism for considering or giving special considerations to NDPs with financial difficulties, whether they're related to Hong Kong residents or not. We would look at them on a case-by-case basis, judging their financial capabilities and other factors. We could actually reduce their fees. Chairman, could you give us more details? When did you ever use the mechanism, and do you have any figures? Well, I think, Chairman, I think you need to give the government time to respond. And other members may not have time to ask their questions. Could you be brief, please? What kind of mechanism were you talking about? Yes, the fee remission mechanism is for people eligible who could apply. And for NEPs, simply put, if their financial situation or the family's financial situation is inadequate or is such that they're unable to afford the fees, or if they can't, the persons involved cannot leave the territory yet, we will consider whether to reduce the fees charged. Next one is Regina Ip. Chairman, I agree that people in private wards and without close relations to Hong Kong people should be charged full fees. As mentioned in the annex of the paper, for many wards, the daily cost actually of ward actually is over $4,000. So we have to look at the catering costs. So now you charge patients about $1 a day. So in Hong Kong, if you can go into a public hospital, then you'll be taken well care of. And the service level is even superior to that in Europe or North America. So if you are non-local residents, you should be charged the full fees. As for NEPs, whether we should give special consideration to spouses of Hong Kong people, well, this issue was raised with former Secretary Mr. Jia before. He gave a rather rigid answer, saying that HA only has limited two types of categories of eligible people. But times have changed. Before, the mainland women who come to give birth in Hong Kong were charged much less than now anyway. So for those, whether they're eligible or not, you need to update the definition of eligible and non-eligible people. I agree with Mr. KK Kwok that Hong Kong people who have mainland spouses, spouses who come on one-way permits, many of these families have very limited income. And you know that now with the internet, you can check on these people's information very easily online, from the immigration department. You can easily check on the internet whether their spouses are permanent residents in Hong Kong. So that's easy. And you can get an answer in a very short time. So I think you should consider a more humane option by taking this group of people into consideration. Yeah, Undersecretary, yes, it's all about the same question. I think maybe I'll say this again. When it comes to the fees, the private patients, in comparison with NDPs, private patients have to afford a high amount of fee, even though they're charged on a cost recovery basis. But NEPs actually are charged less than private patients. So therefore, given that HA has already given consideration to NEPs, that is, we're not treating them the same as private patients. But private patients is 150% of the cost recovery. That's reasonable because you are getting private services, on the basis of our social resources. Of course, private patients, people have nothing to do with Hong Kong, should pay more. And someone pointed out that I tried myself in the U.S. when I had an accident. I was admitted into a Oregon hospital, and I had to pay full cost for my treatment. So it's reasonable. Any supplement? Sorry, no supplement. Next one is Poon Siu King, Chairman, Public Hospital. For the same item, charges less than that in private hospital. I'm sure you have data for comparison. Annex 2 mentions the radiography and also other special treatments whose costs have risen a lot. For example, interventional radiology procedure costs up to 15,000. But I'll ask, how do you set the criteria for the charges? Okay, I can ask Dr. Young to supplement. Yes, Mr. Poon, Chairman and members. Under the current system, back in 2003, about a decade ago, the fees were set. And over the past decade, with advances in medical technology, the introduction of radiology procedure and non-invasive procedures and so forth, a lot of new items have been introduced. So the proposed charges this time, the HA adopt the same principle for setting the fees, that is to recover cost and also to make reference to prices in the private market. Why do we make reference to private markets? Because if our charges are way below the private market, then this would attract people who can use private services to get services at public hospitals. Just then, Mr. Pong mentioned the interventional radiology procedure, whose charge is proposed to rise to 51,900. For this amount, we are talking about a new technology, and also other related technologies have advanced a lot. So we adopt the principle that we need to determine the cost on the basis of the duration of surgery and the amount of manpower involved. And this level is also set in comparison with that in the private market. So you can see the range of charges at the top end seems quite high, but to a large extent, this is because of this large increase is because of the latest advancement in medical technology. So you can't compare it strictly with the range of charges set back in 2003, because we're talking about, in fact, various types of levels of technology. Wang Big Wen next. Thank you, Chairman. Just members asked a similar question about the cross-border families, Hong Kong-China families. I propose that you should reconsider come up with a clear differentiation between private patients and NEP. And you should also consider under NEP to include people whose spouse is a Hong Kong person. Because these type of people should be charged as locals. We've talked a lot about women born to married to Hong Kong men to get paternity services in Hong Kong. Now we have to make sure not just there are enough beds for these women who are coming to Hong Kong to give birth, but there have been suggestions for women married to Hong Kong men to be charged the same as local wives. They're the same as Hong Kong women, except that they haven't lived here for 7 years. So these people have asked you to cut the fees, and yet now you're proposing to raise the fees. So if you stick to this paper, you will have difficulty getting it passed in the Finance Committee, and there will also be opposition outside.
So how should you treat these members of Hong Kong mainland families? These are cross-border families with low income. So should we regard them as outsiders, not related to Hong Kong in any way? So is it that as they can't satisfy the 7-year residence requirement, they won't get any subsidy at all with regard to public sector medical services? So I really hope that you can give special treatment to members of Hong Kong mainland families. Yes, Professor Chen, thank you. In fact, a few members have made this request, so I can fully understand members' concerns. So we're willing to look at the matter. But I want to say that the hospital authority looks at this issue from the point of view of providing subsidies. At the moment, the hospital authority is providing a subsidy of 98%. So the hospital authority will have to look at its own mechanism. At the moment, the hospital authority's policy is to provide subsidies only for Hong Kong residents. We've heard members' requests. Yes, I think we will look at whether the policy should apply to non-Hong Kong residents across the board. So we were not being discriminatory. It is just that the hospital authority, in obtaining resources, in allocating funding, looks at the issue from the perspective of providing subsidies. Yes. Dr. Yang? Yes, thank you, Chairman. Concerning persons related to Hong Kong residents, we follow the population policy formulated in 2002. Under the present framework, they are regarded as non-eligible persons. So if the administration looks at the policy again, then of course we will work in accordance with the policy. Now we've got this paper in 2004. The clerk has drawn my attention to this paper. In fact, the definition or the definitions of EPs and NEPs were laid down by the administration, not in the legislation. Before 2003, mainland spouses of Hong Kong residents were EPs, but then the policy changed. So can the Undersecretary explain why there was such a change? Before 2003, spouses of Hong Kong ID card holders and their children under 11 years old were treated as eligible persons. So it seems the definitions are decided by the administration, not by legislation. Under Secretary, do you have such information? I've got some information for members. On the 1st of April 2003, the new definition for eligible persons came into effect. In September 2002, the administration set up the Task Force on Population Policy. The task force reviewed the eligibility for the use of subsidized public services. With regard to public housing, social security, it was agreed that a certain residence period had to be fulfilled. But this residence requirement did not apply to other services. And with regard to public sector medical services, those on two-way permits and also the transient population were able to enjoy such services. And at that time, the task force was of the view that the opportunity should be taken to rectify certain problems in the system so that resources could be used and allocated in a rational manner. And then the administration came up with the definitions after having considered a number of factors. My understanding is that at that time, the objective was to make sure the public funds were used to subsidize those who were regarded as eligible persons. And I don't know whether calculations were made at that time with regard to the financial implications when the old definitions were maintained or kept. Yes, Mr. Chang Kwok-Chu. Thank you, Chairman. I want to echo the concerns of other members with regard to mainland spouses of Hong Kong residents. In fact, these mainland spouses can choose to give birth to their babies in the mainland, but they want to come because if the babies are born in Hong Kong, the babies are permanent residents of Hong Kong. And also, some of them are giving birth to their second baby, and so they can't give birth to the second baby in the mainland. So they have to come to Hong Kong to give birth to the baby. So it's not a matter of abuse. And then if we have Hong Kong women marrying mainland men, then there will not be a need for their spouses to come to Hong Kong to give birth. So why is it that we are penalizing certain Hong Kong residents and their spouses? Here we don't see the obstetric service fee package. Previously, there was a punitive element in the fee. There was a penalty, financial penalty. And I would like to know what the financial penalty is or will be with the coming into effect of the new fees and charges. Yes, I think Dr. Yeung can answer this question. Yes, Chairman, thank you. In this review, we did not cover obstetric service for non-eligible persons. That is because in May, we adjusted the fee for the gate-crashing pregnant women to our A&E departments to $90,000. Now, we didn't intend to punish or penalize anybody. We were just aware that there were lots of pregnant women who wanted to gate crash our A&E department at the last moment, and that would be rather dangerous. But what if they do not use your A&E department? Is it that there is a policy whereby if you have surplus capacity, then you can accommodate mainland spouses coming to Hong Kong to give birth to their babies? But I want to say that this year we had an exceptionally high birth rate among local women. That was because many Hong Kong people felt that this year was an auspicious year. So in other words, you have no surplus capacity. No, we have no surplus capacity. But in case you have surplus capacity, what will the fee be? If it's gate crashing, not gate crashing, they just come through the normal channel. 39,000, but then we provide the package only when we have surplus capacity, but we won't have surplus capacity in 2013. But it's still $39,000. If they book an appointment, then the fee is $39,000. Mr. Fernando Zhang. Yes, Chairman. We've been following up on this issue of mainland spouses of Hong Kong residents for a long time. I can remember that 2 terms ago, I and Kiki Kwok expressed grave concerns about the issue. It's clear that this policy is discriminatory towards mainland women and also most Hong Kong people except civil servants. Now, I hope that the Undersecretary can confirm this point. Now, if a Hong Kong civil servant has a mainland spouse, then if the mainland spouse wants to come to Hong Kong to give birth to the baby, then that mainland spouse is regarded as an EP, not an NEP. Am I right? Undersecretary, can you please explain? Yes, thank you. Now, here, I think Dr. Fernando Zhang is referring to such a situation, and that is under the CSR, civil servants enjoy medical benefits and also their spouses enjoy certain medical benefits. Chairman, so civil servants are covered or protected by the CSR. Other Hong Kong people are not protected by such regulations. So other Hong Kong people don't get such protection. So, Chairman, how should the panel deal with such a discriminatory policy? Undersecretary, I believe it's not legislation. I believe you are only talking about the terms or the terms of contract between the government and civil servants. Yes, you are correct, Chairman. So why is it that under the terms of the contract of employment, hospital authority has to provide such services to the spouses? Yes, you may want to pay for the fees and charges for the civil servants. So in the employment contract, you may promise to pay the fees and charges for the civil servants. But then it doesn't mean that they can be guaranteed a bed or a place in a hospital authority hospital. So why is it that for the others they can't get such treatment? Chairman, I hope that you can give me some more time, 30 seconds, okay? But because she was unable to answer my question. Now you have about 2 minutes, Undersecretary. Concerning this technical point about whether the hospital authority will reserve a place for the spouse of a civil servant, Dr. Yuan can supplement. Now, of course, our resources are limited, and so we give priority to Hong Kong residents, local residents. But of course, we also take care of civil servants and their dependents. nobody is allowed to jump the queue. They are civil servants and dependents, and they are regarded as EPs. No, but then there are some who can't even join the queue. I'm not talking about anyone jumping the queue. There are some who are not allowed to queue up. And also, you can see that there's a big difference between fees for EPs and then fees for NEPs. And then acute cases, $990, general ward, $4,600. I can remember that in some years ago, a visitor contracted SARS. He lived in a hotel in Hong Kong, and he had to pay $990 for A&E treatment. And what if he went to the A&E department, he was diagnosed to have come down with SARS, and then he had to pay $4,680 per day for staying in a general ward? And what if he said, oh, in that case, I would just stay in the community, I would not be hospitalized? Then what would be the harm done to society? I want to know whether this fee policy only looks at financial implications. Do you look at the public health angle?
HA with the Center for Health Protection are in close contact, and she said all the epidemics, should they happen, definitely we will handle them, tackle them from a public health perspective. And the scenario you just mentioned, I think all along the HA, in relation to NEPs, HA does have an estimate of how many of them can afford the fees. And should the authority be aware that there are people who cannot afford the fees, there is a mechanism in place right now to offer fee remission or reduce the amount. So it's particularly for NEP with financial difficulties. So I hope that with this arrangement, people with financial difficulties, NEPs will not be denied the medical services they need. I think it sounds dangerous. I hope that you have heard us today. If you just rely on frontline officers to make a decision later on whether someone will be given the support, then this is not tackling an issue from public health perspective. I hope that you can reconsider the entire policy. Firstly, remove the discrimination, and secondly, put public health first. Fees should not come before public health. It is not that important at all. Next one. For I think adjustment of charges for NEPs, has the administration reviewed and studied the chances or the figures of NEPs defaulting on their fees? According to the HA and the report in 2010, the default amount amounted to $40 million. That's a rise of 23%. NEPs are responsible for more than 20 million of the default payment, and that makes up about 78% of the total amount of default. So, and we need to chase these people up for payment, but then the success rate, as far as I know, is really low. But you worry that if you raise the fees, will the default situation intensify? And have you got any measures to make sure that you can catch these people who default on the payment? And also, have you got any ways to recover the default payments? Maybe, Under Secretary, I know that your voice is really weak, so maybe you can ask somebody else to answer. Maybe I'll ask Dr. Yang to answer. Dr. Yang, as for default payment, in 2011-2012, NEPs defaulted on about $31 million. And this amount is something that is under our review. And also, on your other question, the default payment includes, we do have, data on deposits, and also the default payments included other miscellaneous fees as well as the telephone bills. Since 2007, for all NEPs, if they had default on any payments, we would stop providing any non-emergency services to them. That is, when they arrive, if we find from our computer that they have not settled their previous payments, then we would decline to provide to them non-emergency services. But if there are some fatal problems with them, or if mentioned by a member, if they could be a carrier of a virus, then we would definitely provide services to them, no matter they have paid all their past payments or not, payments due or not. But there are some amounts that we could not identify where they originated from, because sometimes we could not locate the people involved on the addresses they had provided us. So therefore, there's no way we could recoup these outstanding payments. If we can, if possible, we would, try to recover the payments through legal means. Okay, another question is, it was about 10 years ago when you adjusted the fees. Would you consider increase the frequency of reviews? Because if you don't adjust the fees, then taxpayers will be paying for the differences in fees. So do you have a mechanism of having a regular review of fees every 3 years or 2 years? Under Secretary, would you increase the frequency of review? Sorry, could you repeat your question again? Did you mean that in the future will we continue to review the fee structure and the principles? Yes, if I remember correctly, it was about a decade ago when you revised the charges. So I think the difference, difference in fees actually have to be shouldered by the public. Would you consider reviewing the fees every 3 years or 2 years so as to cut down on the taxpayers' expenses? Well, in reviewing the fee structure, HA actually carries out a constant review, but every time when we do it, we need to consider factors, a basket of factors. Therefore, it's not necessarily the case that a review would lead to increase in fees. The HA would have a periodic review. Maybe Dr. Yang can supplement. Dr. Yang? Chairman, members, HA every year reviews the unit cost of our key services, and data are also disclosed to the government in our report. As we review our costs and whether additional fees should be imposed and so forth, we will look at the entire or the overall economic environment and the public affordability, as well as the cost of drugs, as well as any other inflation caused by advancement in technology. Over the past decade, we also considered, because during the past decade, there are 4 times when the government froze public fees. So there's a basket of factors for we to consider. And we also initiated a discussion within the Bureau. I think in the days ahead, we would continue to have regular reviews, and the proposals will be submitted to the Bureau for its consideration and discussion. Next one is Chen Heng Bang. Thank you, Chairman. As for mainlanders married to Hong Kong people, I know they are not given the priority services because of the overcrowdedness of maternity wards. But this actually brings out a number of issues and uncertainty to these spouses. I hope that the government will review the situation later and try to find a solution to tackle the problem facing mainland spouses of Hong Kong people. Now, back to the issue of defaulting on payments. How serious is the situation of default in the past? And would you copy what the private hospitals have done, that is to ask the patients to pay deposits when they're admitted? Are there any ways to prevent defaults? Undersecretary? Dr. Yang is prepared to answer it. Yes. As I said before, for the NEPs or private patients using HA services, we do charge them deposits. For NEPs, according to the existing fee structure, we will charge them $33,000 as deposit. For private patients, we will charge a deposit of $40,000 to $100,000, depending on what kind of surgery they are in for. Even if someone is remain in the hospital after admission, our colleagues would issue temporary receipts to the private patients or bills to patients. So we've seen defaults on payments for administrative services. We have asked our colleagues to trace these people up by calling them to pay. And in the past few years, in fact, the number of people defaulting on the payment has dropped. I hope members understand, the situation. Any follow-up question? I'd like to know about the rate of decrease and any figures available for us for reference. Yes, I can provide you with some figures later on. Next one is Lillian Chiang.
有關呢個符合
Chiang Lai-wan. I'd like to ask about the situation of NEPs and EPs. I'd like to ask about, for example, domestic helpers. They're all eligible, are they? Yes, I just like to confirm this. Yes, they are eligible. Okay. And also foreign students in Hong Kong, are they eligible? Yes. Are they? Students coming from the mainland? Well, I don't care where they're from mainland or not, but people or students coming from outside Hong Kong, are they eligible? If they have Hong Kong ID card, then they are eligible. But they come on a student visa. When they get a student visa, they will be given an ID card. So as well, yeah. So these students, they probably have not taken out any insurance in Hong Kong. Why did I ask this? Because when I was a student studying overseas, I had to buy local student medical insurance. So the insurance was given by a designated government unit. Whenever I got sick, I was entitled to medical services. And it's compulsory for me to buy that insurance. I don't know about the arrangement in Hong Kong. What do we require of students coming from outside here? Ms. Chiang, on your point about overseas students, I think Hong Kong, unlike America, makes it compulsory for students to have taken out an insurance by the time they enter the country. But if they have Hong Kong ID cards, then they are entitled to all HA services as eligible people. So anyone who comes to Hong Kong and feels sick, of course, I would hope that we can take care of these people as well. But I think ultimately Hong Kong's medical services should serve mainly our permanent residents here. So I think we need to encourage overseas students. We should introduce some kind of a system, to, whether we call it student insurance scheme, to encourage them to get the insurance so that the government can estimate, the possible costs, medical costs it would need to shoulder for them. And the government can claim the costs or the expenses back as well, so that students would not find themselves unable or having much difficulty paying for the services. Because I heard that there are situations or scenarios of people defaulting on their medical bills, and you did review the situation of defaults and you have come up with ways to prevent defaults. But my question remains, how do you get the payments back? Have you tried to chase some patients for their outstanding payments? People who owe the Hong Kong government money, have you tried to chase these people up for the payments? And what do you do with them? They are owing the Hong Kong government money. They are owing HA a lot of money, and then just, leave and then come back to Hong Kong 2 weeks later to shop. What can we do with these people?
Undersecretary, as Dr. Young has pointed out, if we have records showing that they have defaulted in payment, then we will only provide emergency service. We will not provide non-emergency service to them. Then many of them are non-Hong Kong residents. I think we should recover the money from them. Can you talk to the Customs and Excise Department? These people owe Hong Kong money. That's a fact. Yes, I thank Ms. Chang for her comments. Right, second round, KK Kwok. Yes, Chairman. I want to clarify one point. Is it that apart from mainland spouses, all spouses of Hong Kong residents who have obtained ID cards are regarded as EPs? Yes, they are EPs. Because spouses of other nationalities can get ID cards. So these spouses may come from 107 countries and they can get ID cards and they are EPs, but then mainland spouses are treated differently. Dr. Yang told us that there was a fee reduction arrangement. I want to know whether this policy is written in black and white. All patients are aware of this policy. In the past 5 years, how many people applied or benefited from this arrangement? Now, Chairman, I have a motion here urging the administration to change its policy. But in the interim, I think the concessionary fee policy can help these mainland spouses. We don't know how long it would take for the administration to review the policy and to change the policy. So I think the concessionary fee arrangement is the only way to help these spouses from the mainland. Yes, I think Dr. Young can give members more information. Yes, Dr. Young. Chairman, perhaps I can supplement. Mr. Kwok asked whether spouses of other nationalities are eligible persons. Now, for visitors, now if they are visiting Hong Kong and staying on a temporary basis. Of course, they are only NEPs. And then local spouses, some of them are on two-way permits, waiting for one-way permits issued by the mainland. And so these two-way permit holders are similar to visitors on temporary stay in Hong Kong. But then once they've got one-way permits, although they are not permanent residents yet, they become eligible persons. And concerning the concessionary fee mechanism, in fact, hospital authority frontline staff and medical social workers know of the existence of this arrangement. In the year 1011, $41 million was spent with regard to the concessionary fee arrangement. And then in 1112, the figure is about 30 million. So I want to know whether these figures merely applied to mainland mothers. These figures apply to all NEPs. But do you have a breakdown? I want to know the figure for mainland spouses of Hong Kong residents. Yes, please continue. In fact, in the hospital authority, Chairman, we don't have information showing us whether they really have any links with Hong Kong. In fact, our patients do not really need to tell us whether they are linked to Hong Kong in any way. But with regard to 1112, according to our figures, a total of 14,000 cases involving NEPs benefited from the concessionary fee arrangement. So, in fact, we have this policy is a clear policy. Our medical social workers can assist if the patients tell our social workers that they have financial difficulties. Alright, so can you give us more figures after the meeting? For example, the amounts of fees reduced, number of beneficiaries, and so on and so forth. All right, Mr. K.K. Kwok would like to move this motion. This panel urges the administration to treat mainland spouses of Hong Kong residents, EPs, and all discriminatory policies against them must be scrapped. All right, if now Dr. Joseph Lee, if you leave this conference room, we won't have a quorum. But let's make copies. Let's make photocopies first. And so we have the movers. The mover is K.K. Kwok, seconder Mr. Chiang Kwok Chu. And then I heard you say that in 2013, if there is surplus capacity in hospital authority hospitals, then mainland spouses can get obstetric service at the price of $39,000. Is that right? If there is a surplus capacity in hospital authority hospitals in 2013, then mainland mothers can enjoy the obstetric service at the price of $39,000. Now, in fact, we do gazette all the fees for our services. And for NEPs, not gate crashing, our A&E department who want to make use of our hospitals for obstetric service, they are charged $39,000. But then, even if they come forward to book an appointment, we have to look at whether we have surplus capacity. Next year, we'll still give priority to local residents. My question is clear. If there is surplus capacity in public sector hospitals in 2013, then is it that mainland mothers will be charged $39,000 so long as they are not gate crashing our A&E departments. All right. Second, para 14. What do you mean by other persons approved by the CE of the hospital authority? That's para 14B. Dr. Yang said that he would give the information to members after the meeting. Here, I think we are talking about very special cases. You say EPs are A, Hong Kong residents according to the basic law, and B, other persons approved by the CE of the hospital authority. And you can't tell me which categories you are referring to here. Right, if you can't give us the information now, please give us the information after the meeting. And then concerning Mr. K.K. Kwok's motion. Chairman, I agree that we should seek such information from them. So what are the persons approved by the CE of the HA? Who are they? Yes, Under Secretary. I think the Deputy Secretary can give members an example, or Dr. Yang can give an example. For example, prominent political figures from overseas, and the CE of the HA can charge him the EP fees. All right. Overseas prominent political figures. Let's deal with Mr. K.K. Kwok's motion. Right? Do I need to read it out? Chairman, I have a related question. Does the administration have figures with regard to the number of mainland mothers, number of cases every year? If you can't give a reply, I can answer on your behalf. About 6,000, right? As Dr. Yang has said, among NEPs, we do not subdivide them into Hong Kong mainland families. But previously, such information was provided to us. Now, Chairman, now in the obstetric department, the mothers may tell us that their spouses are Hong Kong residents. What about non-obstetric cases? Can you tell Mr. Chen about this? What figures do you want, Mr. Chen? Now, for example, when we're talking about mainland mothers, do we have an approximate figure? How many are we talking about per year, for example? How many may come to Hong Kong to give birth to babies? There is no way we can make an estimate. In fact, most of these mainland mothers register with private hospitals, and so the hospital authority doesn't really have that figure. If I remember correctly, for mainland spouses or of Hong Kong residents, obstetric cases in hospital authority hospitals, about 6,000 to 9,000 in the past years. All right, this motion is relevant to the item being discussed, and so it's in order. Chairman, I think let's put this to the vote. If members want to object to it, let them object to it. All right? All right. Can we put this motion to the vote? Those in favor, please raise their hands. 5. Those against? No objection. Abstentions? No? So we have the majority of members voting in favor of the motion, and so the motion is approved. Next item on the agenda. We'll have another team of officials, right?
The next item is strategy and measures in prevention and control of seasonal influenza. Government's paper and the background brief have been given to members. So may I ask the administration to take us through the paper? Thank you. The paper sets out the administration's plan, including additional preventive measures and enhanced healthcare support to prepare for the coming influenza season. We know that Hong Kong has entered the peak season of influenza. Because of this, the Center for Health Protection and also its subordinate public health centers actually have stepped up their checking of the situation. And we do expect an increase in the number of people seeking help with flu. And virus infection is also expected to become more common. And every year Hong Kong experiences 2 influenza peak seasons, one in the winter and the other in the summer. The last influenza season was quite special because in January this year to July this year, that was when the whole season was on. It lasted the whole 7 months. And also recently, the whole world was hit by some new diseases. For example, in the United States, there were virus H3N2 that was transmitted from pigs to humans. In the Middle East, there's also a new type of virus, coronavirus, that led to fatal respiratory diseases. These 2 new diseases have not yet been spread to Hong Kong, but because of various factors, the government in the 2012-2013, in preparation for the upcoming influenza peak season, we need to increase our vigilance and we need to call on the public to be aware and adopt preventive measures. On the level of public health prevention, together with the HA and CHP, we would come up with various measures to tackle the peak season. Apart from HA and the Center for Health Protection, we continue to maintain ties with clinics, nurseries, and old people's homes and so forth to closely monitor the cases of flus. as well as the data of people admitted to ICUs because of flu, or cases of deaths resulting from flu. Should there be an epidemic, the Center for Health Protection would carry out epidemiological investigations to try to contain any outbreaks and take emergency measures such as school closures. As for the measures involved this year, the government will continue to provide free vaccination program for children and the elderly. Particularly this year, the government has increased subsidy for childhood influenza vaccination to the same level as that for elderly people. This is to encourage more parents to take their children to clinics for the vaccination against influenza. We're very pleased to know that there are more private doctors who have reduced their consultancy or consultation fees, and more than 300 clinics, as far as we know, in view of the government subsidy, has not charged their patients extra for vaccination, and this is double the figure last year. The HA has also taken various measures to assist with the target cluster groups to receive vaccination, including medical staff. We'll continue to monitor the effectiveness of the vaccination program in terms of the safety of the vaccines and their effectiveness, and also measures against influenza. We do hope that the general public would consider vaccination for their own sake. Of course, all the measures I mentioned above require the support of the entire community, and this is, to prevent an outbreak of epidemic. We do call on the public to continue to be vigilant and also maintain personal hygiene, be alert to hygiene. We have with us the representatives from the Center for Health Protection, the controller of the center, in fact, Dr. Thomas Zhang, and also Dr. Lee from HA, who will give you more details on the various measures to prevent and control seasonal influenza. Dr. Zhang first. Thank you, Chairman. Just some details here. As mentioned by the Undersecretary, winter has come and we need to monitor and see whether there's an increase in the cases of flu. I think in a couple of 2 months, or in about a couple of months, the peak season will arrive, and we will we do expect the vaccination program to be quite an effective measure against the influenza. And government clinics are actually providing vaccination free for eligible people, and the scheme began in November. And secondly, for private doctors, the public can receive subsidized vaccination at the clinics. Elderly people and small children are entitled to the free vaccination in a scheme that began in September. By December 12th, public response to the programs have been quite good. Compared to last year, we have 14% increase in the number of vaccinations, particularly for the ratio of children vaccinated. The ratio actually has gone up by 60% compared to last year. Besides vaccinations, we are also stepping up publicity on radio, TV, or other public media, such as public transport, on maintaining personal hygiene. And should there be an outbreak of flu in old people's homes and other nursery homes, we would definitely step up investigations there. We also study where there is a new strain of flu virus or any antiviral virus. And we also continue to monitor the latest influenza trends in the region, and we will release the latest information to the public whenever the information is available. Okay, totally. Yes, for HA, during the flu peak period, it will pose a lot of pressure on our A&E department, and there will be more actually patients suffering from respiratory diseases. Every year, around the peak period, we will closely monitor the figures provided by the Center for Health Protection. Most of the pressure for work will come normally a week after the CHP registers an increase in cases. And to reduce the risk of a flu, we would actually liaise with community nurses and also services for the elderly to strengthen support for old people's homes. This could help us simple flu cases in the nursery or old people's home, so that this could reduce the pressure or the number of people using our A&E department. It can also help reduce complications. And often for flu cases, family members would be very worried, particularly the patients are children, and they would be taken to clinics during the peak period. So normally doctors' clinics will be very crowded, and people have to wait for a long time. So within clinics or ANED, we would try to increase the observation zone to increase the space for patients, and also we will allocate more staff to handle ANED cases. And also during the peak period, we will increase the diagnosis of the virus, so that parents would know better whether the children are actually having influenza or affected by any particular virus. And also for hospital beds, we would actually try to arrange for our staff not to be away on leave during the peak period, so that there can be more people looking after the patients in hospitals. And we may also provide overtime pay to attract more people to work, and also we'll also create temporary beds to take care of the extra number of patients admitted because of flu. During the peak season, especially during the long holiday, for example, during Christmas, New Year, or Easter holidays, we will increase the number of doctors' visits to wards. Even if the doctors are on holiday, we will also increase the frequency of inspections in the wards. This could help reduce the time patients wait for the drugs they need. So we're trying to speed up the entire work process to accommodate more patients. We will also increase the support of ancillary medical teams, as well as medicine undergraduates to provide temporary or emergency help. When the situation gets serious, we will reduce the number of non-emergency surgeries, except those for cancer. For non-emergency surgeries, we will try to reduce them to create more space or manpower to help the flu patients. So we would also try to reduce the number of non-emergency surgeries being carried out in January and February. Around this time, we also increase public propaganda to ensure that, or to alert the public to maintain good health and to have good rest and wash their hands more frequently, to observe personal hygiene, and to see private doctors first before they rush to the ANED. And should they find themselves in ANED, they need to be patient, because there'll be more people waiting for services. So that's the wrap-up of our measures. Thank you. 3 members have asked to speak. Each of you will have 4 minutes. Kwok. Chairman, I'm very pleased that the government has a new plan. From 6 months to 6 years old, and also those aged above 65, there's no problem with that. The problem is for children who are from 6 to 12 years old, or people who are aged about 50. So what about them? What support do we have for them? In the Disease Control Center in the United States, it adopts the basic principle that everyone, as long as is 6 months old, he will, and he can benefit from vaccination. And also for children and also people aged above 50 or people with chronic illness or as other categories mentioned earlier who are covered by the government support. But I just want to ask you to expand the vaccination program to primary schools as practiced in some schools, and also that has been proven to help reduce the number of disease or admissions into hospitals, expenses incurred from flu. So I'd like to ask Dr. Zhang, do you have any data to convince us not to cover the above types of people I just mentioned in the vaccination program? Will we actually lose more than what we gain if we don't include these other groups of people in the program? We are talking about social costs because apart from seeing a doctor, if you're sick, you lose the days to work, so there's a loss in manpower as well. So has the government carefully considered expanding the vaccination? In many places, the support or the subsidy would not be limited to people above the age of 65.
Then, secondly, I understand that the two vaccination programs cover children from 0 to 6 years old and elderly persons under, or rather, over 65. I want to know whether medical and healthcare staff working outside the hospital authority are covered and whether they know of these vaccination programs. Dr. Zhang. Yes, thank you, Chairman, and I thank Mr. Kwok for asking these extremely valid questions. In Hong Kong, we have a scientific committee to study the vaccines, and every year the scientific committee comes up with some recommendations. Now, in fact, the scientific committees are of the view that persons of all ages can receive the vaccines so long as they do not have very serious contraindications. So it is confirmed that these vaccines are suitable for persons of all age. And then concerning whether there are high-risk groups in the community, the scientific committees have already come up with some groups: elderly persons, children, and then pregnant women, those with chronic illnesses. They are all high-risk groups. The scientific committees wish to remind them that they should be vaccinated. With regard to primary school students, they are not a high-risk group as viewed by the scientific committees. Now, for hospital admissions because of flu, if we compare those from 0 to 6 years old and those from 6 years old to 12, you can see that the admission rate for primary school students is lower. You can say that if for primary school students, if they have flu, then there can be an outbreak in schools, but still the admission rate is lower among primary school students, especially when we compare them with children from 0 to 6 years old. And then we provide free vaccination to the high-risk groups as recommended by the scientific committees. We also look at the financial situations of the chronically ill and pregnant women, if they are on CSSA, then they will be covered by the free vaccination program. But then if they are not on CSSA, say for example, if there is a 50-year-old diabetes patient who is working and is not on CSSA, then this person is not covered by the free vaccination program. And in fact, we do ask the scientific committees to review the situation every year. And so the scientific committees may in future give some different recommendations. Chairman, but just now I mentioned the social cost. So has the administration weighed the expenditure and the social costs or versus the social costs? Dr. Zhang, now I am not aware of the existence of such studies, especially for primary school students. But of course, if there is a need to carry out these studies, we can ask universities or tertiary institutions whether they are interested in carrying out such studies. Yes, Mr. Prinsipe. Yes, I to share Mr. K.K. Kwok's concern. It's important that we try to prevent a flu outbreak or pandemic. The administration referred to the recommendations of the scientific committees, and the scientific committees looked at the hospital admission rates. But we are told that the primary school students are not the high-risk group. Now, say from 6 years old to 8 years old, 9 years old. So I want to know what the financial implications are if we want to extend the vaccination program to cover primary school students, say up to 8 years old, 9 years old, 10 years old. So do we have such figures, please? Under Secretary, we don't have such information with us. But of course we can come up with such estimates. I don't think it's really difficult to have such estimates. Dr. Zhang, do you have anything to add? We don't have accurate estimates. But then when we call tender, it costs us about $30 to $40 per dose per vaccine. And for those under 9 years old who haven't been vaccinated against flu before, and they have to receive 2 shots. And I believe Census Department does possess some of the information, and also have to take into account the manpower costs, for example, those administering the injection or the vaccination. I want such information for reference. So I want to know whether in future we can expand the coverage of the vaccination program. Yes, I think we can provide the information. We'll take on board members' comments, and we'll also reflect members' concerns to the scientific committees. Ms. Helena Wong. Yes, thank you. It is said here that the take-up rate of the vaccination program is not very high. I believe the public would like to know whether the vaccines really work, whether they're effective, and whether there are side effects or contraindications. So can we have some expert advice as to whether such vaccines are effective, whether there will be side effects? And do you have any study results showing that the vaccines are effective, or the vaccine it's better not to get vaccinated than to get vaccinated? And then assuming that these vaccines are effective and do not bring any harm, then I think we need to look at another issue. Now you require people to go to get vaccinated at hospital authority clinics or hospitals or government clinics. But then for elderly persons and also those living in homes for the elderly, they can't go to the hospitals or the clinics for the vaccination. It's very easy to have an outbreak in a home for the elderly. In fact, my mother lives in a home for the elderly, and from time to time there are flu outbreaks. Yes, Undersecretary. Chairman. Now, as Dr. Zhang has pointed out, we have the scientific committee, and the scientific committee has already confirmed that the vaccine is suitable for everybody. So there are very few exceptional cases. And then the member would like to know whether we have proactively reached out to homes for the elderly. My understanding is that some hospital authority clusters do reach out to private and subvented homes for the elderly, but then the coverage will not be comprehensive. Dr. Zhang perhaps can give some information. Yes, Chairman. We are concerned about the situation in a home for the elderly, because if an elderly person gets flu, then complications may easily be developed. So we do have visiting nurses going to the homes for the elderly, so that these elderly persons do not have to go to a government or private clinic to get vaccinated. And I think the coverage is about 80% at the moment. And of course, the Undersecretary has also mentioned other measures. And then concerning the effectiveness of the vaccine, in fact, there have been studies, and for a healthy person, the prevention effect can be 80 to 90%, and for an elderly person, the death and hospital admission, the chance of these can be reduced by 50 to 60%. So although the protection is not 100%, still there is a high level of protection against flu, right? Ms. Elizabeth Quat? Thank you. According to the paper, we had two flu peak seasons, January to March and then July to August. So I want to know whether one injection can cover both peak seasons. And then I have been told that the virus keeps mutating, and so it's useless getting vaccinated. And also there are many who haven't been vaccinated, and so many of them have come down with flu. So I'd like to know whether one shot is enough for the entire year to cover two peak seasons, and whether one shot or one vaccine can cover different types of viruses. And then we are concerned about kindergarten students. Some have suggested that the administration should proactively send people to kindergartens to provide shots for the children, because not all parents will take their children to the government clinics for vaccination. Yes, thank you. I'll answer the second question first. Now, we do reach out to homes for the elderly and hostels for the disabled in the vaccination program. But this outreaching program doesn't cover kindergartens. In deciding whether we can expand our outreaching program, we have to look at whether we have enough manpower resources, and we can only, for the time being, target the groups with the highest risk. And also, now, if we want to provide shots for the children, we have to have the parents' consent first. And if parents can take their children to get vaccinated, then that of course means that they consent to the children getting vaccinated. And we think that's better than sending someone to the kindergarten to provide the service for children. Dr. Zhang.
Vaccination is supposed to be taken once a year and done every year, because the flu virus always mutates. So normally, we suggest that about 4 weeks before the peak period is the best time for vaccination, because it takes time for the vaccines to take effect. Should the flu strain mutates in that period where there's a need for another vaccination, but so far there hasn't been any country that requires people to take 2 vaccinations in a year. So we mainly follow WHO's recommendation, which is that to be vaccinated once a year. As for the question on nursery homes, just as you mentioned, parents' consent is required, but I have heard from many parents who think that should schools ask parents to sign up for vaccination, they almost, all of them would like to agree. I don't think it will require much resources. You can show us how much money we're talking about if we require all schools to provide vaccinations. In the last 2 years, we've seen outbreaks of flus in some nurseries. So parents are very concerned about that. If the government doesn't take the lead, then we need to explain to the public why you're not doing it. As for vaccination, I know January is the peak period, and it's best to have the vaccination in December, right? Undersecretary, thank you for your view. First of all, that is, many parents, should they want vaccination for the children, we will definitely take that into consideration, and we will find out the reason why we are not providing that now. Dr. Zhang? Yeah. This year, the subsidy for small children has been increased this year, and there are also 300 odd doctors who are not charging extra for example, vaccination for a 3-year-old. I know parents often are very concerned about the children's health. I know many of my relatives and friends' children, whenever they have a small problem, minor problem, their parents will take them to see a doctor. We'll try to help parents find a suitable doctor for them. As for when to have the vaccination, as I said, don't wait till the peak arrives. The body does need time to develop the ability to be immune to the disease. So it's best to have the vaccination before December, ahead of the peak season in January. Yes, I think the government needs to think of how to reduce parents' burden. For each parent to make an appointment to the doctor, it's quite troublesome. For some parents, they may not be able to afford the time. So I hope that the government can come up with a simple method and just get the vaccinations to be offered at all nurseries. Is that? Next one, KK Kwok. 2 questions. In the past, before the peak period, HA would carry out some drill exercises. We're lucky in the past few years we haven't seen any major outbreaks of flu. I'd like to know whether you're going to have any drill exercises. In the past, the first part of the exercise was carried out by the Department of Health or HA during the SARS. The entire government, including its emergency center, also carried out the drill exercises. So do you have such a plan, and when? And also, when there was flu that happened in the States, the group most affected was those not vaccinated, that is, those under the age of 50. So there was a view then that whether there's a need to change the preventive approach. You said everyone can be vaccinated, but we have to understand that, the government plays a driving force. And in Hong Kong, there are still a number of low-income groups who may not be getting CSSA, and yet who are not rich at all. So for some groups of people, people who should be eligible for the subsidy, we need to think about whether there can be flexibility. That is, for some low-income groups, for example, people who fall into the category you mentioned, like the chronically ill or pregnant women, can they ask for subsidy? You know that we are now giving out medical coupons for elderly people, but those who are not elderly and yet low-income groups are not given any support. Often I was stopped on the street and told that, well, I'm 59. But I'm not entitled to any sort of subsidy, even if the person, for example, is a diabetic. So I think the government need to review its current approach. You want to provide relief aid to people who are poor, and on the other hand, you're trying to provide incentive for people to avoid being affected by the flu. You don't have to answer me now, but you might need to change your mindset to provide support to people who are not that poor like those who are eligible for CSSA. I know that many people who are actually better off than CSSA recipients actually may not seek help. So you can provide for vaccinations at general clinics. There are costs involved in general clinics providing vaccinations, but if you subsidize such clinics, then this could be a kind of solution for the particular group of people. But I'm interested in knowing from you whether you're going to have the drill exercises and your discovery in 2009 has that had any effect on your decisions? Yes. Thank you for your suggestion that you want us to review the existing policy. Let me reiterate that the government's policy on the subsidy and other public health services is based on the principle of providing help to the high-risk group and also to the most needy. The HA, for example, is using taxpayers' money and is using public money to subsidize hospitalization costs. So the basic assumption is that we are helping those most in need and so forth. I know there are people who may be in need and yet are not covered by our subsidy. But of course, there are people who are in need who may not actually need our subsidy, to vaccinate. So if we are to include one more group, then that will have implications on our resources. So we need to look at the entire picture. And also, just then you mentioned about whether we have any plan for drill exercises. May I ask Dr. Zhang and Dr. Lee to supplement? Dr. Zhang first. Thank you, Chairman. As for drill exercises, in January, we are planning to carry out a drill on the coping with flu. The details of such drill exercise will be released to the public soon, and media will also be briefed. And in 2009, we discovered a new strain, of flu. And that was a new strain because for age group from 50 to 54, this strain proved to be more actually damaging to this age group. So the high-risk group definition actually was lower from age 65 to age about 50. So this is a kind of judgment because of the latest evidence and findings. So should there be a 50-something person who's on CSSA and who wants to be vaccinated, we would provide that vaccination for that person free. As for the drill, yes, we're trying to tie in with the center's action. Yes, I think this is an issue with the Bureau for people aged about 50 who are not on CSSA and who are getting support. But I'm not going into detail on that. But my second question was, in the past, the entire government is involved in the drill. Should there be an outbreak of flu, all discipline services and other government departments, AMS and so forth, support units and so forth, are they going to be involved in the drill? Will the CE be vaccinated? I'll ask another doctor to answer. Yes. Every year we will carry out drills, and often the drills involve various government departments. For example, if it's an evacuation similar to the scale, similar to what happened during the SARS period, then we would actually involve the various government departments. And whatever opinions you have on the future drills, you're welcome to let us know, and we can include your suggestions in the planning. So are you saying that for the latest drill, no government departments will be involved? Yeah, no, there will be. The various government departments will be involved. Yes. Okay, members? Okay, I've got some questions here. I'm particularly concerned about staff at public hospitals. At a time of a surge in diseases, the workload will increase. And you're saying that you are prepared to create 500 temporary beds in children's and other wards to cope with the peak period. Can you tell us about the actual extra hours of work that would mean should there be increased number of hospital beds? And how are you going to allocate resources among various hospitals? Often HA's resources are not necessarily given to areas where resources are most needed. So can you tell us the what is the extra cost of the additional working hours? Well, Chairman, we haven't got the data yet because the flu peak season hasn't started. We only have the emergency measures on hand. How serious the flu season will be, we don't know yet. So what you meant is, You're not expecting the 500 beds, extra beds to be provided in January. Well, we prepare for the additional capacity. So we're prepared. Once the emergency measures are kicked off, once the peak season arrives, we will be able to provide the beds anytime we need it. But there are so many public hospitals around, and each hospital will be under different level of pressure. Some may be congested earlier than the others. So it all depends on the supply of beds in each hospital. When we decide when to have the extra beds ready. But we are sure that our resources, the manpower, are enough to support the provision of additional 500 hospital beds. Well, with the extra beds, you would anticipate extra working hours, right? You know 500 odd beds will be needed. How about the manpower and extra working hours needed? Yes, each bed, well, once you have additional wards, you also have to have additional doctors and nurses. So we have our rosters planned already. When there are additional beds, we will allocate staff, nurses to man the beds, and we will also increase people's working hours by giving them extra payments and so forth. So can you give us supplementary information, because you only have given us the number of beds in your paper. How about the man hours? How about the additional hours expected for various levels of staff? What's your estimates? Can you provide us with information later? Yes, I can only give you an estimate. Let me give you an example. Say if the demand for service increased by 10%, well, may not be what happens later on, but this is just an estimate. It can vary later on, and the situation may vary from hospital to hospital. I can only give you a general estimate.
Concerning such whether we've really reserved such resources. Now, I want to say that in order to maintain our level of service, even though we need to overspend, we still need to provide such services when needed. I think it's about time to adjourn the meeting. AOB. Now, tomorrow, 4:30, there will be a special meeting to meet deputations on the development and operation of private hospitals. And I understand that Dr. Zhang will leave the administration very soon. And on behalf of the Health Service Panel, I would like to thank Dr. Zhang for his contributions over the years to the public health situation in Hong Kong. So we wish you all a very happy retirement life. Thank you.